So the question was about whether email access to physicians or nurses or healthcare providers improves adherence. And it's a terrific idea, and there's no good evidence, to my knowledge, that exists to date. This is like a tricky issue as well from an efficacy kind of effectiveness standpoint. There's tremendous face validity. On the other hand, do you want patients emailing you nonstop? You know, how do you have decision rules? How do you deal with boundary crossings and all those sorts of things? There is good evidence that's emerging that automated kind of reminders, so maybe it's not a human being contacting you, but some sort of sophisticated algorithm, whatever, that learns about your preference, that works fairly well. WellDoc, for example, is a company that has a very interesting product. Yeah, sure, you bet. So the question is around like differences with ethnicities and cultures with respect to adherence. Developing cultural competence is an onerous task. Okay. What I would suggest though is that if, as a start, if you are dealing consistently with a particular kind of ethnic minority population, whether it be like South Asian, where there's a high problem with hypertension, or Aboriginal First Nations group, there are training modules that are available if you were so inclined online that can help. For example, in BC, there's a very interesting module to build cultural competence around working with First Nations population. Anyone in Canada can take it, but it does require some investment of time. I think about 8 hours of your time, and you have to complete it within a month. The first step along the cultural competence road, however, is doing what you just said, which is to acknowledge that you have biases, particularly if you're a member of the majority group. If you think you don't, I think you do. Thank you.